Blood! What do we do? What do we do? Panic is a fairly normal reaction when a patient comes into the emergency department vomiting blood, like our friend Mark here. But it's important to keep a clear head on your shoulders and make some quick evaluations to determine the cause. In this case, Christos is presenting with hematemesis, and he gets an EGD at the end of the case that actually tells us the cause: esophageal varices. But even if he didn't have the EGD, there are some big clues in his case that points you towards esophageal varices as the cause. He has hepatitis C induced cirrhosis, which means he could have varices, but he has evidence of portal hypertension, specifically his ascites and the caput medusae, or those engorged paraumbilical veins. And where there is portal hypertension, there's more likely to be esophageal varices. His vital signs are not bad, for now, but they could be moving in the wrong direction for sure, so he could probably use a little resuscitation. He's intubated because of the hematemesis, a smart move considering his oxygenation is dipping, meaning he's probably aspirated some of that blood already. Then Christos undergoes an EGD, which is much less scary when he's already been intubated. Don't have to worry as much about his airway during the procedure. They find some nice bleeding esophageal varices and band them. Woohoo! Wait, uh-oh. Less than 24 hours later, his hemoglobin is falling again and there's blood from his OG tube. I guess we're not done. We are asked, what is the next best step in the management of this patient? Over 50% of patients with cirrhosis will develop esophageal varices, and up to a third of those will have a serious variceal hemorrhage. Variceal hemorrhage is a huge cause of mortality in patients with cirrhosis and requires prompt diagnosis and treatment. First, a little anatomy, as it's crucial to understanding the pathophysiology of varices and remains a favorite on tests. Portocaval anastomoses are natural connections between the cable, i.e., systemic circulation, and the portal system. There are three main connections to remember. First, the connection of the left gastric vein, which is portal, to the distal esophageal veins, which are cable. Portal hypertension can lead to esophageal varices here. Based on the location, esophageal varices, therefore, can be expected to develop in the distal esophagus near the GE junction. Next, the connection between the superior rectal veins, which are portal, and the middle and inferior rectal veins, which are cable, can lead to internal hemorrhoids from portal hypertension, or just from sitting on the pot too long. That poor, unsuspecting, unsupported perineum while you're reading the news on your iPhone. We know what you get up to in there. But that's all a story for another sketch. And finally, the paraumbilical veins, which are portal, to the superficial epigastric veins, which are cable. Engorgement of these veins due to portal hypertension leads to the pathognomonic caput medusae commonly seen in cirrhosis. Think of the veins like Medusa snakes all around the umbilicus, and you should easily remember this pseudonym. That reminds me of our clinical case. Christos, those squiggly worms over your belly are actually veins. There we go. By far the most clinically relevant are esophageal varices, which can rupture and cause life-threatening bleeding. Oh my god. Forget the blood. What is that thing? Oh, it's terrifying. Just like esophageal varices. Remember that portal hypertension tries to relieve itself down the path of least resistance, which means it's going to end up pushing blood that should be filtering through the liver out and into these portosystemic anastomoses. Esophageal varices are very shallow and can become engorged, ulcerate the overlying mucosa, and cause life-threatening upper GI bleeding, which gives people just like our buddy Christos from the clinical case a really bad day. In contrast to other sources of upper GI bleeding, such as peptic ulcers, this bleeding only stops spontaneously in about 50% of cases, making intervention necessary in these cases. The bleeding may manifest as either hematemesis or as melena, or even hematochezia in the case of distal bleeds. Ew, not only is this hydra attacking us, but he's pooping in the water too? Gross. Patients may have a history of EGD and banding of varices already, but easily could have been lost to follow-up. The source of hematemesis may be suggested based on the patient's characteristics, such as ascites or other evidence of cirrhosis. However, if the patient is already intubated, such as in our case, it can be difficult to obtain such history. Remember Christos from the beginning? He had a fair amount of history giving the diagnosis away. Not all patients will be so obvious. Ooh, hello, Mr. Muscles. Hot damn. Alright, so we have a guy from our case throwing up blood. What's next? As with other causes of acute hemorrhage, the first step in management is placing two large bore IVs and making a quick run through of the ABCs. Moderate to severe hematemesis has a high risk of aspiration and pulmonary complications, making airway protection via intubation necessary in these patients, just like Christos from our clinical case. With airway and breathing out of the way, which is a twofer if they get tubed, it's on to circulation. Patients with acute variceal bleeding need prompt crystalloid and blood product resuscitation, though extreme care should be taken not to fluid overload cirrhotic patients. While acute hemorrhage transfusion requirements generally state to keep hemoglobin over 7, blood transfusions in patients with variceal bleeding should be given to maintain a hemoglobin of greater than 8 to 9 in patients with ongoing hemorrhage. However, it's very important to note that fluid overloading of cirrhotic patients can lead to rebleeding, so blood and fluid should be given very judiciously. With aggressive crystalloid and blood product administration, you can correct blood pressure and hemoglobin while diluting your blood clotting factors, which could cause more bleeding. Let this paratrooper chick remind you that if the PT-INR is elevated, replacement of clotting factors with fresh frozen plasma can be done. Wait. Did they have paratroopers in Greece? I'm digging the fighter pilot Pegasi as our recurrent sketchy symbol for FFP, though. What is this, the Greek Avengers or something? All these muscles. Though I'm not really sure how much help a discus is going to be against a hydra. In patients with active hemorrhage, platelet transfusions should be used to keep the platelets over 50,000. Again, remember that aggressive transfusion may be counterproductive. Increased intravascular fluid may increase portal hypertension and cause more bleeding. Feeding it fast food. That's probably a fairly wise move. As blood travels through the GI tract, it's digested into urea, which is then reabsorbed, raising BUN. This high BUN impairs normal metabolism of ammonia, which can build up, resulting in encephalopathy, particularly in patients with cirrhosis and already malfunctioning livers. The man of the hour, Herc himself. He's wielding the mystical spray bottle of doom. In these cases of acute encephalopathy, lactulose can be used. In intubated patients, remember lactulose can be given via an NG or OG tube or per rectum. Lactulose functions by causing increased stooling and also helps rid the GI tract of bacteria and acidifies the colon, which prevents ammonia uptake by converting it to ammonium. Treatment of varices is complicated. They're difficult to get to, so even though direct pressure is the best treatment for any general source of hemorrhage, it's often impossible in bleeding varices. See this guy here struggling to stop all that blood? Other strategies, therefore, must be used to slow blood flow to the bleeding veins. Initial treatment involves optimizing the patient, and usually begins before pursuing definitive treatment. Octreotide, a somatostatin analog, decreases splanchnic blood flow, which reduces the amount of blood coursing into the varices and subsequently can slow the hemorrhage. IV octreotide infusions should be started immediately in cases of suspected bleeding varices without confirming the presence of varices and should be continued for 3 to 5 days. There you go, dude. Lasso that hydra. Alternatively, vasopressin, which causes splanchnic vasoconstriction, may be used. Vasopressin also causes coronary vasoconstriction, and thus should be used cautiously in older patients with coronary artery disease. Furthermore, vasopressin shows less of an effect on mortality than octreotide, making octreotide the drug of choice. Patients with cirrhosis and variceal bleeding are at high risk of either already having an infection or developing one during their hospital stay. This is not due to the bleed, but rather due to the patient's cirrhosis putting them at higher risk. The most common infections are UTIs and SBP. Therefore, prophylactic antibiotics, typically ceftriaxone or fluoroquinolones, should be given to all patients presenting with acute variceal bleeding. Well, it's been a minute since we talked about our clinical case. It wasn't mentioned explicitly in the stem, but I'll bet most of these were already done for our boy Christos. With the patient all tuned up with octreotide, crystalloid and blood product resuscitation, and antibiotics, it's time to move on to definitive treatment strategies via upper endoscopy. Endoscopic variceal ligation, EVL, is the best treatment for active variceal hemorrhage. And that's just what happened with Christos from our clinical case. With EVL, an endoscope is used to find varices, which are then suctioned into a special suction channel. With the varices raised up from the mucosa, an elastic band is slid over the suction channel, ligating the varices at their base. While it sounds easy enough in theory, it can be quite difficult when there's hemorrhage clogging up the camera's view, and this requires an experienced endoscopist. Endoscopic sclerotherapy, which involves injection of sclerotic agents that cause necrosis and fibrosis of the variceal tissue, is another alternative. While it is effective, it has a higher risk of complications, making endoscopic banding preferred in most cases. So, how come Christos bled again? Another problem with esophageal varices is that once they bleed, they tend to rebleed. A lot. Especially within the initial 48 hours of therapy, meaning therapy failed. Risk factors for rebleeding include renal failure, large varices, age greater than 60 years, and severe bleeding at admission. A rebleed is defined as a bleed occurring more than 5 days after admission, provided that the initial bleed was successfully stopped for 24 hours. If there's another bleeding episode within those first 5 days, even if initial treatment was successful at stopping the bleed, it's considered a treatment failure. Thinking back to our clinical case, Christo's technically having a treatment failure. And I think we're getting closer to the answer to the question. If varices rebleed after initial endoscopic therapy, band ligation may be attempted again due to its high success rate, which pushes 90%. All right, everyone, there's the answer to the question. In short, let's get Christos back over to the GI suite and try the same thing again. However, in patients who rebleed twice, or where the initial bleed was unable to be stopped on the first attempt, more invasive measures are warranted. Control of hemorrhage may be accomplished with balloon tamponade, which is exactly what it sounds like. A Sangs taken Blakemore, often just called a Blakemore, or Minnesota tube can be inserted into the esophagus and passed into the stomach. Once in position, the stomach balloon is inflated and pulled backward into the GE junction, thereby tamponading varices of the GE junction. If needed, a separate esophageal balloon can be inflated temporarily for mid-esophageal varices. It's critical to be careful with the esophageal balloon, though, as prolonged use or high pressure can lead to esophageal necrosis or perforation. A tamponade balloon is only a temporizing measure, not definitive treatment. Remembering that varices are secondary to portal hypertension, reducing the pressure in the portal system may help slow a bleed. One way to reduce the pressure in the portal system is to literally drain the blood out of it. This can be done in a variety of ways, though the transjugular intrahepatic portosystemic shunt, TIPS, is preferred. During a TIPS procedure, a catheter is inserted into the right jugular vein and advanced retrograde into one of the hepatic veins, thus entering the liver. A shunt is deployed through the hepatic vein, through the hepatic parenchyma, and into a branch of the portal vein. This creates a connection between the portal vein and the inferior vena cava, allowing blood to bypass the liver and reducing the overall portal pressure. The TIPS procedure has a success rate of 90 to 100% in treating variceal bleeding, so it works. It also avoids the need for general anesthesia and open surgery in a cirrhotic patient, who is a high-risk surgical candidate. TIPS can't be used in all cases, however. Contraindications to TIPS include heart failure, severe pulmonary hypertension, systemic infection, and severe tricuspid regurg. Ooh, wow. One of the Pegasi got loose and he's looking pretty crazy right about now. One of the main complications of TIPS is hepatic encephalopathy, as it increases the amount of blood that bypasses the liver without being properly filtered of toxins, and in particular, ammonia, which results in encephalopathy. If all else fails or the patient has a contraindication to TIPS, the only option may be surgery. The decision for surgery is a big one, because remember, patients with cirrhosis are very high-risk surgical candidates. Surgical shunts, such as a portocaval or splenorenal anastomosis, can be used to divert blood from the portal to caval circulation, reducing the portal pressure. Esophageal transection can also be performed to remove varices. In this procedure, the esophagus is transected, varices are ligated and removed surgically, and the esophagus is reclosed. Any open operations in cirrhotic patients are more dangerous, with a mortality rate of about 50%. But this may be the only option to control severe hemorrhage. Most cases of variceal bleeding can be treated endoscopically or with a TIPS procedure. But you're not quite done yet. Patients should undergo repeat endoscopy with band ligation 1 to 2 weeks following the acute bleed to reduce the risk of rebleed and to band any non bleeding varices, which was not done during the acute bleeding episode. Non-specific beta blockers, such as propranolol and nadolol, are also indicated to help prevent recurrent bleeding. Propranolol and nadolol block beta adrenergic signals to the splanchnic vessels, resulting in unopposed alpha activity, vasoconstriction, and therefore reduced splanchnic and portal blood flow. With reduced portal blood flow comes reduced portal pressure and subsequently less risk of bleeding. Once a cirrhotic patient has a variceal bleed, they should undergo screening EGD every year, especially in decompensated patients, to find and band any new varices. Whew, that was stressful. While these guys keep wrestling back all these heads, let's sum up what we've covered. Esophageal varices occur in approximately 50% of patients with cirrhosis, and of those, 1/3 will have serious variceal hemorrhage. Esophageal varices are one type of portocaval anastomosis and are a connection between the left gastric vein and the distal esophageal veins. Esophageal varices, therefore, can be expected to develop in the distal esophagus near the GE junction. The other types of portocaval anastomoses are the internal hemorrhoids, where the portal superior rectal veins anastomose to the systemic middle and inferior rectal veins, and the paraumbilical area, where the portal paraumbilical veins anastomose with the systemic superficial epigastric veins. This is called caput medusae. Esophageal varices are the most clinically relevant. They become engorged, ulcerate, and then can bleed. This can present as hematemesis, melena, or even hematochezia. Acute hemorrhage should be treated according to the ABCs. Patients at risk of aspiration and/or pulmonary complications should be intubated for airway protection. Resuscitation should be prompt and judicious with both crystalloid and blood products, remembering that fluid overload may exacerbate the bleeding. Hemoglobin should be maintained above 9. Attention should be paid to the coagulation factors, particularly with the PET test, and FFP should be given if there's coagulopathy. Platelets should be maintained over 50,000. BUN may be elevated in these patients due to blood passing through the GI tract and being digested. This may result in encephalopathy, which may be treated with lactulose. Prompt initiation of octreotide or vasopressin may help decrease the blood flow through the portal system and thus slow the bleeding. Prophylactic antibiotics are frequently given for prevention of developing infections or treating infections that are concurrently present with the bleeding. Definitive treatment of esophageal variceal hemorrhage requires EGD and usually band ligation of the bleeding varices. Sclerotherapy is an alternative treatment, though band ligation has less complications. Rebleeding is common, and the factors that increase risk of rebleeding is severe bleeding at admission, renal failure, large varices, and age greater than 60 years. If bleeding is not stopped with EGD, more invasive measures must be taken. Balloon tamponade involves inflating a balloon tube within the stomach and pulling back to lodge it at the GE junction. Another balloon may be inflated in the esophagus for continued bleeding. The esophageal balloon, however, can cause necrosis and perforation if left up for too long. Another invasive measure is a transjugular intrahepatic portosystemic shunt, or TIPS procedure, where a shunt is placed via intravenous catheterization between the portal and systemic systems, resulting in decreased pressure in the portal system. Contraindications to TIPS includes heart failure, pulmonary hypertension, systemic infection, and tricuspid regurgitation. The main complication of TIPS is increased risk of hepatic encephalopathy. Surgery is another option. However, it's important to remember that cirrhotic patients are at very high surgical risk. Open surgeries in these patients carry a mortality of approximately 50%. Surgery may be used to create other types of shunts, such as portocaval or splenorenal shunts. Esophageal transection and surgical resection of the varices is also possible, though highly morbid. Patients are usually treated endoscopically and should have follow-up EGD 1 to 2 weeks after the bleeding episode. Patients are often started on nonspecific beta blockers like propranolol or nadolol, which help reduce the splanchnic blood flow by causing unopposed alpha activity, resulting in vasoconstriction, and the final result is decreased portal venous pressure. Finally, Once a patient is diagnosed with a variceal bleed, they should undergo yearly EGDs to monitor for other impending bleeding varices. Whoa, look out. This battle's getting pretty nuts. Come out of here. Yo, buddy, you got room on that ferry boat? Cool. What's your name? Karen? Seriously? Well, at least this isn't the River Styx. Oh, it is? It's cool. Hercules will save me. Hey, Herc! 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 Oh god. Oh god, I'm too young to die.
No,
Too pretty?